So Joe kind of gave me this title, and we've heard little snippets of lots of things which are very important aspects of this work already in other talks. And I didn't actually go into too busy slides, so actually some of Konstantin's slides I avoided showing, but he has them in his talks, and I think you've probably got copies if you want to know some of the minutiae. But really I wanted to try and take a bit of a step back, because we do have a role in helping talk to kids with MEN1, whether it's MEN1 or MEN2, but actually of course a lot of that talking starts at home. And it's a little bit false and engineered, because of course when you come up to the genetics clinic or if you go up to a hospital, it's often a set appointment. You haven't chosen the time, you haven't chosen the place, you have to go along with the flow. But of course the conversations that you're going to have with your children start at home, and they won't happen at preset times. They won't happen even when there's anything related to MEN1 that's happened that week. But it'll happen because something has connected with a question that they want to ask. And really what I'm trying to do with this talk is to help you to gain an understanding, so that when those questions come up at home or within the broader family, you'll have some tools, some ways of answering some of those questions. Because if you're comfortable with talking about it yourself, then hopefully you can help with those answers. And of course we're there to help when that is the right time for families to come forward for genetic testing. And hopefully with Project Superhero, that will be another really important part of the jigsaw puzzle in trying to help you and the whole family come to terms with the genetic side of the disease. So we've already talked a bit about genes. Actually, probably some of our kids are much more au fait with genes and genetics than we ever were, because a lot of them have things like Genes for Genes Day. They go in wearing their genes, and there's some sort of talk about genetics and inheritance. And so a lot of them have some awareness that genes are quite important. And so the genetic code is really, all the genes are within the nuclei in each cell. They come in pairs, and the genetic code isn't actually a very exciting read. It's only got those 4 letters in it. But the order of those letters is so important, and that every letter should be there in the correct order for a gene to work. And we've probably got about 25,000 genes in every cell in our body, and they're all responsible for different things, so they're all there for an important reason. But there's some overlap with some genes and their instructions. But everyone is needed for normal growth and development. And we know that genes come in pairs, one from each parent, and sometimes both genes need to be working, depends on the nature of the condition. And we know that each of us has a few genes which don't work properly. Konstantin gave some very large figures from what we're understanding with this new step forward we've got in technology and the way that genes and whole genomes are being analysed. But certainly with MEN type problems, if there's one gene that's faulty, the protein might not work properly, and therefore that might lead to medical problems, and in particular tumours. So these are some of the endocrine tumour genes that are currently known, and there will be more which will come out, I'm sure, in my working lifetime. But I think most of you here have got faults with the RET gene or the MEN1 gene menin, but those are some of the other genes that we can now pinpoint and diagnose within the genetic endocrine clinic, and it is increasing. So if we talk about carrying genes, everybody has a pair of MEN1 genes. One has come from your mum and one has come from your dad. And so we all carry a pair of those MEN1 genes. But if there is a fault in one of the genes, then that will increase the risk of certain tumours. So just one gene that needs to be faulty, but that itself can lead to the risks. So in normal population, people can develop parathyroid adenomas. We've seen clear evidence of that. And in fact, for them to develop a parathyroid adenoma, often there are changes within the gene, but only within the genes within the parathyroid gland in order for that tumour to grow. And that's why it's often a later onset problem, because it's cumulative effects over somebody's lifetime. Whereas if you have an inherited predisposition to developing tumours or cancer, so you've got that inherited faulty gene which has been there in every cell in your body from birth, you're already further down the line to getting tumours. And so with another spontaneous event, when there's 2 faulty genes, then that will predispose the person to developing a tumour or a cancer. And that's why often the tumours develop earlier, because you're already closer to those tumours happening. But as you can see, there's no date stamps on any of this. And we've already heard about penetrants. If we do a genetic test, it doesn't then say, but you're going to get a tumour in January 2026. We don't have that information. We just know you're more likely to, and therefore the aspect of regular medical care and surveillance is so important to help to pick things up before they've become a real problem. So it is important to do genetic tests amongst all the other tests that we've been hearing about. And we know that in certain genetic endocrine tumours, there's quite a high likelihood that we'll be able to detect genetic faults. And we can normally interpret the results because we've been doing these tests for some time, and we know very clearly with some gene faults, particularly in the RET gene, we know exactly what that may lead to in terms of disease. And so that gives us clinical usefulness in using that as a test. And certainly once we know what the gene fault is in the family, that'll give us much clearer ideas as to whether we can offer other tests to other family members who are at risk of the disease but haven't yet developed problems. And it is important because in families who had late diagnoses of endocrine tumours, that may have led to very severe problems. And certainly I know of families where there have been sudden deaths because there have been undiagnosed pheochromocytomas in the family. That's what we'd like to avoid if genetics and regular screening will be part of the medical care for the families in the future. And then, of course, if a family knows of a gene fault and somebody at risk of the gene fault has a test and they're found not to have that gene fault, then they won't be at that increased risk of all those tumours. They'll still have a population risk of getting these tumours, but you've heard figures of 1 in 100,000, 1 in 20,000. These are very rare tumours, so in general they won't be at risk of that disease, and they won't need any medical follow-up in the absence of symptoms. So we've heard a lot about genetic testing today. There's really two sorts of genetic tests that are offered to the genetic clinic. The first is a diagnostic or a mutation search test, because that person is the first person in their family who's come up with endocrine neoplasia. And at that point, unless there are particular clues from the background family history, we may not have a clue as to which endocrine gene we're going to need to concentrate on, or we'll have a clue as to some, but we don't know what the answer is going to be. And so that first test is a bit like looking for a needle in a haystack, because certainly in MEM1, we're going to have to look at the entire length of the gene and look at it. It's a bit like proofreading a book. We're going to have to look at every letter, every full stop, to see that they're there in the right order, nothing missing, nothing lost, nothing added in. And then when we've done that test, maybe 90% of the time we'll be able to find the relevant gene fault. For RET testing, it's a little bit easier because there are very certain gene faults in certain areas of the gene. But once we've got that diagnostic result, then we can move on to offer targeted or predictive tests in the remainder of the family, because we now know what the exact gene fault is. And so that makes it a lot easier in subsequent tests, because we're only going to get one of two answers. We're going to find that an individual at risk has got the gene fault or hasn't. So a mutation search test, they are getting better all the time, and we've already had a conversation. Somebody was asking, is my test correct? Well, if it was done in an NHS accredited laboratory and they've got a mutation report saying what the gene fault is, that's a verified test in a quality assured lab, and that is the correct answer. If it was done in a research lab, or perhaps a fault wasn't identified and it's more than a decade, things have moved on, and therefore it might be a chance to look again to see if we can identify what's going on for that person, and then obviously for the broader family. We always need consent to do a genetic test, and that's because we're going to be finding out very important information, and it may have lifelong repercussions. And so if you've been to my clinic, there are forms to fill in about consent. It's a different consent to having an operation, but we still need to talk through the issues about whether it's the right time to have a test and the implications of the test result. And in terms of young people, we use a standard that over 18 they can sign their own consent forms, but under 18 they could be, we call it Gillick competent, in that they may know what they want to do, but normally we'd ask them to have the support of the adult to sign saying they're willing to go through that test. And under 14, obviously, we'd expect the parent to take that responsibility. We normally need a teaspoon of blood for a genetic test, Occasionally we can use spit samples, but blood samples are normally the best. And for a mutation search test, we get an answer in about 2 months. If it's just one gene that's been looked at, if it's a whole panel of genes, actually it's about 4 months. But that's not normally for MEN1 and MEN2. And so these are the possible outcomes that we can get. And this is just thinking, I know there aren't any people here necessarily with paragangliomas, but paragangliomas and pheochromocytomas, there are now at least 9 genes that we want to look at once. And so that's why it takes about 4 months. So we might look at people's genes, and I've just put 2 of that panel up here, and we're going to get 1 of 3 results. We might find no faults by doing a genetic test. And then we've got to ask ourselves, well, is it that this is a sporadic tumour, or is it actually that we've not detected a genetic fault on that test? And that will very much depend on what else we know about the individual and what else we know about their family. Or we might find what we call a grey result. They call them unclassified variants or variants of unknown significance. We found a spelling mistake in the genetic code, but we don't know whether it's actually going to have a bearing on how the gene works. So we just think about the name Stephen for a minute. You can spell Stephen with a V in the middle or a PH. Doesn't matter how you spell Stephen as a name, if you pronounce it correctly and Stephen's on the other side of a crowd, he'll wave back at you. So that's what I call by grey result. It is a spelling mistake. They've picked it up on their laboratory test, but they don't think it's significant enough to alter the function of the gene. And in that situation, we haven't actually managed to find the genetic fault that we think has led to the tumour, and we're not going to be able to offer that test to other family members. So what we're hoping if we offer genetic testing is that we will find on a diagnostic test a gene fault that we know is concretely going to lead to endocrine neoplasia, and in that situation we'll then be able to offer cascade screening within the family. So pretest counselling is important, and even when it's involving a child it is important, but it's quite difficult to talk to children if you've never met them before and they're coming onto your clinic and their only thing that they know about the clinic is that they're going to have a blood test. And so I think Project Superhero is going to be fantastic because it'll give us some other ways of introducing the topic. It's not just me saying it to you as a child or a doctor talking to a child, it's actually normalising something that they're about to go through. And I think it will be really, really helpful. So I just think of some of the children I've had in clinic who are at risk of MEN or who've got an endocrine tumour where we need to do a diagnostic test. Certainly in those under 7, they haven't really got any questions to ask about the condition. At that age, they're really only noticing different colours and eyes and the fact that somebody wears glasses or has got a hearing aid. Those are the sorts of differences they can think about. But they can't really grapple with the same concepts and ideas that we know we need to explain to the adults. And so certainly children of that age, it's very much a question of ensuring that the parents can understand and take on the responsibility for having their child tested. Between 8 and 11, I've met some other children, and in particular, I remember this one child I met. He was 8. He'd had a pheochromocytoma. He'd had a very rough ride in the sense that he'd presented with intermittent symptoms and then had really bad headache and a stroke before being admitted, and his pheo being sorted out. But there was absolutely nothing in the background history to suggest why that should have happened when he came to see us. And so he came for a diagnostic gene test, and it was just really important for us to try and unravel what was going on to help plan what else needed to happen for his future care. And in fact, he ended up having an SDHB mutation, but we'd excluded some of the other forms of genetic faults that we might have needed to look at. And so that gave us some very clear follow-up plans for him, and then that gave us an answer for the family. And in fact, in his family, his mum and one of his grandparents had the same gene fault, but they were well, and they hadn't yet developed any problems themselves. So it very much depends on the age. I had another child who came who was 11 who was at risk of SDHB, and his only question that he wanted to sort out before he had the genetic test was, could he go skiing if he had the gene fault? And you may say, you may trivialise it, but you know, that was the biggest thing that was happening in his world in the next 6 months. And so it's very hard for children to think about the lifelong consequences of having a genetic test. But obviously it's really important as adults that we can help them prepare and think through things and answer questions as honestly and truthfully as we can at the time. And so it is about learning about your own condition and the breadth, because not everybody will have the same experience as you, and I know you know that from what you've heard from other people in AMEND, but if you only rely on one source of information, that may not be the broadest and most balanced source of information. And certainly if you look on the internet, and we know from medical literature, it only tends to be the worst extent of cases which get published. It doesn't necessarily show the full breadth of what's out there. And so, or it's, you know, it's lagging behind where the reality is. So it's very important to be up to date and as truthful as possible. So thinking about the inheritance, we know that all genes come in pairs. We know that every parent has a chance to pass on half of their genetic makeup to their children, either through the eggs or the sperm, but it is completely random as to whether they hand the 40 gene on or not. And it's a 1 in 2 chance, however many children you have. And so it really is a 50-50 chance, just like tossing a coin every time you have a child, as to whether you were going to hand on the 40 gene or not. And how you explain this is difficult within the family, because you yourself, if you've just learnt of your diagnosis, I think of a lady recently I've had in clinic, she's just learnt she's got a Rett gene fault in her 30s, and she has 4 children. She's coping with the fact she's about to undergo thyroid surgery. She's trying to protect her children. She's fearful about her own future. She's fearful about her children. And obviously there's always the parental guilt side, which adds an enormous amount to the burden of trying to explain that. So it is difficult, but you're here because you want to improve on the experience for the next generation. And I think, and I hope that with medical science and with the care and what we are understanding, things will be better and will improve. But because we know these diseases are inherited, there is no tablets to change the course of that. We haven't got any way of doing genetic therapy to change the fact that these genes, if they are passed on, could have the same effect in the next generation. So at least one of the speakers also alluded to the fact of penetrants, the term we use to explain why some people go on to develop all the features that could come with the endocrine neoplastic condition, and other patients may not develop all the same symptoms and signs. And so we know that we need to screen people as though they would develop those problems, or possibly offer surgery so that they can avoid those problems, because we can't tell from our genetic studies when that might happen or if it might happen. And certainly in some of these other rarer newer conditions, we know that you can live the whole of your lifetime with that 40 endocrine neoplasia gene and not develop a tumour, and yet, as I explained from that 8-year-old, his grandparent had passed the gene on to his mum, who hadn't had problems, and yet he, at the age of 8, had already developed a pheo. So it can be very, very variable, and so we're learning a lot in some of these newer genes. But in predictive genetic tests, we know exactly what we're looking for within the family. It's a targeted test, so it takes less time. And so we might get an answer in about 4 weeks. So it's still a long time for a child to wait for an answer, but it's a long time for you as parents as well to agonise over what the answer is going to be. And the testing age will depend on the type of intervention. There are slight differences between perhaps UK and US practice, but we are talking about the fact that we would want to offer children tests, predictive genetic tests for endocrine neoplasia conditions, because we know that they can have problems in childhood, and therefore we'd want to offer them screening or surgery to avoid those problems. And so it is a test that we will be offering in childhood. But we've got to balance it against, are we going to be doing any harm? And so I've had a young lady recently, she's got MEM1, and she's just had the second of her children. She's 20, and she'd like both her children tested. They're both under 3. And so we've had a conversation, well, is this the right time? I would say that's too early, but we've got to keep the conversation going, because I don't want her to then feel rejected that we're not going to do a genetic test, and for her to then not bring the children into medical care and surveillance at the right time. So in my practice at the moment, we like, if possible, to test children for MEN1 at around the age of 10, and therefore they will then have some screening during the teenage years when some might develop problems, but over 90% wouldn't. Younger than that, we don't tend to need to follow them medically, and therefore the timing for that genetic test before the age of 10 very much depends on the needs of the family, the discussions that we've already had, how many children there are in the family. If there's only 1 or 2, that might be that we do both of them together. If there's 6 or 7, it might be best that we stagger some of the tests, because that's a lot for a parent to contend with in terms of different answers. And we also want to ensure that parents aren't going to then treat their children differently when the answers come out, because it's very hard, because these test results may produce different results in the family. And so, again, it's a balance, and we're only going to get a snapshot to know how your family works, but we hope to support you to come to a decision with us about the right time to offer that genetic test. And certainly we're still learning. We haven't got a rule book which says you have to offer it at 10. We've had other families who have decided with teenage children that they won't let their children have a test until they're nearly 18, so that they can have input and discussion. And I thought in that family very much valued having 3 years or so to wait for that test to be offered. I've had other families where we've offered it even younger, but it really has varied. But it's important to have the conversation. We don't have the difficulties of money and cost. It's really whether it's ethically correct and whether it's going to be the right thing for the family. So yes, there are difficulties, sometimes risks, because of that altering of family dynamics or possibly stigmatisation. In the UK at the moment, it shouldn't lead to discrimination. At the moment, genetic tests can't be used by insurance companies to differentially load life insurance, critical illness insurance, and that's a moratorium that's at least extended to 2017, and I hope will be extended beyond that. But I'm pretty sure in the States that it could be a problem. Certainly I had one family who didn't have their children tested for MEN2 until they came back to the UK because of the difficulty in getting health insurance.
It's not supposed to happen. We have the President Bush signed the GINA, the Genetic Non-Discrimination Act.
Okay.
So that happened in 2008.
Okay, this family
so
predated that, but yeah, okay. But it's an important thing to be aware of, yeah, so it's something we should have a discussion at least with the parents about. So once a gene fault is found, and I was really pleased to see some of the questions raised in the booklet. What are these differences? Will the gene fault be with me for life? There are lots of things that people find difficult to grapple with. Could it be just sex related? And so these are some of the questions that we've had asked of us in the clinic. My son's tested positive. What's the risk to my daughter? Because if it's happened once, surely that's enough for the family. Well, nature has no memory. It's a 1 in 2 chance every time you have a child, and it's regardless of the sex of the child. And so some families, with a whole brood of children, all the children will be affected. Others it'll be half and half, and others it'll be none. And that's just the way that the gene has been passed on. And it's nobody's fault that has happened. That's just nature's serendipity. And so if a lady had different children by different partners, but she has the gene fault every time she had a child, regardless of the changing partner, there would still be a 1 in 2 chance that the gene fault could be passed on. And again, nothing related to the sex, but people are always looking for extra reasons to explain why what's happened has happened. What about people who find that they've got endocrine neoplasia for the first time? Well, if we found that they've got an MEN1 gene fault, for example, and it's not something that their parents have experienced, it could have occurred for the first time. And so certainly in MEN1, that happens about 10% of the time. We say it's something de novo. In MEN2B, about 50% of those are de novo. So we know it can happen. And so it can seem it has happened out of the blue in some individuals. And that's difficult because you haven't got your family to know much about the disease and what sort of problems it might lead. And so it's a learning curve for you at that time. And then letting go of the fact that if your children have had predicted genetic tests and they've been found not to have the gene, letting go of those worries that you've been holding about their future and their risk of developing endocrine neoplasia. Could they still be affected by MEN1? They shouldn't be, because we've excluded the familial gene fault. And so their risk of getting any endocrine tumour is the same as the general population. So that's rare. And the commonest of all these tumours that we've been talking about are parathyroid gland problems. Average age of 55 and we're women in the general population, but in less than 1 in 1,000 women. So it's not something that we're going to be screening for in somebody who's well. So it is a time to let go of those worries and concerns, because they don't require any specific surveillance. And then one thing that Tom had in one of his slides was, you know, if I've got an endocrine neoplasia type gene and I don't want to pass it on, what options are there? Well, there are reproductive choices for couples which didn't exist 20 or 30 years ago, and that's called pre-implantation genetic diagnosis. There's a license for MEN1 and for MEN2 in the UK. There's a license for SDHB. There's a license for VHL. There probably will be licenses for some of the others out there. So for some families, that's the correct way forward. For other families, it's just best to come and have a discussion before you're planning a family to know what you think you might want to do, because it's very difficult to do anything once you're already pregnant, because we need time. So it's important to come and discuss that with us. And she's not here today, unfortunately, but the genetic counsellor who's in the clinic with me has a lot of these conversations. But PGD is available on the NHS in this country if the conditions are correct. So it's worth having a conversation if that's something that would appeal to the next generation. So, you know, it's definitely a partnership, talking, and I've just put a small diagram up there because young people won't talk at set times about this, and you as a parent will have to work out how best to try and drop relevant pieces of information in as they ask those random questions at what often seems the wrong time of the day. But it's important to keep the conversation going. I think this superhero project will be really, really helpful, because it will help demystify some things, and I hope, again, we'll just set a baseline in terms of dealing with the different issues. But hopefully not to be too scary, but to be truthful. And it is difficult. Sometimes the truth is hard to swallow, but if it's put in the right and sensitive way, then hopefully that will give the right baseline, because we can't brush it off as being nothing. And so it's just how to deal with that within the context of what you're going through too. And I know from my own medical practice that how important AMEND has been in helpful patient information leaflets, because again, it's truthful, it talks about things in its barest form, but also tells you about the different things that you might have to go through, or the different tests or the different scans. But that's important, because otherwise how are you going to know what's involved in screening on a year-by-year basis? And so I think that helps to demystify it, and certainly some of the names and the different results, that's really, really important. And we are learning, we're all learning. Certainly the practice for MEN2 families has changed so much over one generation, but as Tom quite rightly alluded to, we hope we're doing the best, and that will be the best for the next generation. But what's the next leap forward? I don't know, but it's certainly watch this space. But we need to learn from each other. And so when people come to see us in the genetics clinic, we may touch on one of many different aspects when we see them. And it will really depend on how open you are with us as to how we can help you to understand and move forward in the situation. We don't like saying no to things, but sometimes it just doesn't seem the right time for the family, and occasionally we will have to, in our professional judgment, say no. But most of the time we would hope that through open conversation, maybe 1 or 2 appointments to talk things through, that we will be able to come to an answer which is you know, in terms of offering testing, for example, at the right time, is correct for the family. But it does need that open conversation, because at the end of the day, if we've offered a predictive test in your child and they're found to have a gene fault, there will be regrets because they've been found to have the gene fault. But if it was too early, and in fact there's nothing in terms of medical surveillance that is required for a few years, have we actually done the right thing for you, the child and the family at that time? And that's the sort of conversation that needs to happen, and it's hard, but it's an important one to happen. And so, and you know, coping with that uncertainty, how are you going to deal with that? So we've certainly learnt a lot from the families we've seen in the clinic. I know one or two of them here, and so that's why we can't have a rigid rule book, but it's not always right to do the same thing each time. And I think we have to be flexible but sensitive and truthful to work with your dynamics, the family dynamics, and that will be very different for different people. But hopefully with discussion we'll come to the right answer. And we've got some background literature, particularly that study that Professor Metcalf did was very helpful, just helped to map out the sort of things we'd experienced, but we didn't know how common that was. So that was very helpful. And if you want a copy, I'm sure Joe can help give you one, because that was very helpful in terms of thinking through these issues. And normally if you come to the genetics clinic, we're a part of a much bigger network in terms of a multidisciplinary setting, working with the surgeons and working with the adult services as well, because it is going to be a lifelong surveillance and form of contact with the medical profession. And I've obviously talked about my experience offering clinics through Guy's, but you know, there's genetic services all over the country who will be able to be your contact point or your family's contact point, because it's best to go to be seen at your local centre so that they can then feed you into whichever is the local multidisciplinary clinic, because this will be for a long time, and it's important to build up that relationship over time. But certainly we are learning, and hearing stories via AMEND or in whatever way is going to help us all to improve our practice. And you know, occasionally we don't get it right, but certainly through this work that I think is going to come out through the comic, the superhero comic, I really think that that will be a really important tool for us all to have, or resource, because I'm sure it will help fill a gap, rather than going onto the internet and finding information which is unsolicited and isn't necessarily child friendly. I hope that this will be really, really helpful going forward. Thank you for your time.